Okay, so in the previous video, we looked at periodontal health, gingival diseases and conditions, and we examined all these three different categories. Now we're going to look at this classification, periodontitis, and look at the subcategories. So here we have necrotizing periodontal disease. Necrotizing is like a flesh-eating type of disorder. It's like they're eating away the gums. Very, very painful, usually associated with fever. Periodontitis, it used to be called chronic or aggressive perio, and now it's just periodontitis. And then we have periodontitis as a manifestation of systemic disease. Sorry, I'm going to go back and say when someone has any of these conditions, we must stage and grade, and I'll go over that in a bit. Manifestation of a systemic disease. So systemic disease could be diabetes, for example. So this is what staging looks like. This is a chart from the AAP website. And what staging does is it tells you how severe the periodontal disease is, how severe the patient's disease is. And it looks at several things. It looks at cal, and it looks at interdental cal, so the mesial distal cal. It looks at radiographic bone loss. And so when we're looking at bone loss, if we see bone that is 15% bone loss, that would be stage 1. If we see 15 to 33% bone loss, that's stage 2. And if we see extending to the middle third of root and beyond, that's stage 3 or 4. So 15% bone loss, what could that look like? Well, if we know the middle is right here, and this is 50% bone loss, okay, so if the bone was in this area over here, that's 50%. So extending to the middle third of the root and beyond, that's this one. So you find the worst area and you look at this. If the bone level on the worst area is somewhere here or beyond, it's automatically stage 3. 15%. So if this is the CHA, 15% might be somewhere around here. 33% might be somewhere around here. 33, 15, I'm just eyeballing it here. So depending on where the bone loss is in the worst area of the mouth, you would stage accordingly. Then tooth loss, we look at that. So if we've lost 4 teeth only due to perio, stage 3. So we don't include wisdom teeth, we don't include extracted teeth due to ortho, it is only tooth loss due to perio. 5 teeth, they go to stage 4. Probing depths are all here. So when you're looking at the probing depth numbers, they find the highest probing depth numbers. So if they have a 6mm pocket, they go under stage 3. Now, what makes them stage 3 to a stage 4? Well, stage 4, they have a lot of other issues going on. So they can't chew, masticatory dysfunction. They have tooth mobility of 2, class 2 or more. They have very little teeth remaining, that their bite is off, like they can't bite properly. So stage 4 is when they're missing quite a bit of teeth and they've got a lot of other issues on top of the vertical bone loss and furcation involvement. So let's look at this example over here. And by the way, I do have a video that goes over staging and grading. So if you're unfamiliar with this, I do encourage you to watch that video. But here, when we look at this, the highest mesial distal or interdental cal is a 6, right? The highest, probing depth here is a 6, and the highest cal is also a 6. So what does that mean? That means that the highest probing depth is a 6, the highest cal is also a 6. So perhaps this would be a stage 3 and we don't see any missing teeth. Now, if I had, let's say they were missing 5 teeth, then it would, and I had all these circled and this one now is circled, then it bumps them to a stage 4. Grading looks at the rate of periodontitis progression. Is the bone loss gonna resorb at a slow rate? Is the bone gonna resorb at a moderate rate? Or is the bone gonna resorb at a rapid or a quick rate? And so they look at radiographic bone loss over the past 5 years, how much bone loss has occurred. They look at percent bone loss over age. I'm going to show you how to do that. And then they have modifiers. So if you're a smoker or diabetes, you follow this category over here. And again, the video goes over it, the video that I'll link. So let's calculate this percent bone loss over age. Well, let's look at this bone level right here. Let's say this is the worst area in the mouth. And let's just hypothetically, just to make it easy, call this 50% bone loss. Okay, so 50% bone loss. So what do? You take the percent of bone loss and you divide it by the age. So you can see the calculations here. All I did was I took 50 divided by 25. I didn't make it into a percent. I just did 50 divided by 25 and I got 2. What does that tell me? Well, if you have a number 2, that's higher than 1, so that's a grade C. So this 25-year-old who has this condition has a grade C condition, which means they're losing bone at a really quick rate. But let's imagine this person was an 80-year-old. Again, I go 50 because we said 50% bone loss divided by 80, and again, I'm eyeballing this 50%. So divided by 80 is 0.625, and if I look at the chart, 0.625 fall under this rate. So this person, the 80-year-old, would be in grade B. If you're ever in doubt, always go with grade B, and then you can move back or forward based on the modifiers. So let's look at this question. I'll let you read it and you tell me what you think. It is C. So grading does this. Everything else is staging. It does classify the severity of the disease, severity by stage 1, 2, 3, 4. Stage 4 is really bad. It assesses specific factors that might determine the complexity of managing current disease. So if I go to the staging, we can see that where there's so many more other factors, right, that can make it more complicated, make the treatment more complicated. And then it determines the percent of radiographic bone loss. That's this one, percent of radiographic bone loss is in the staging section. But what it does not do is that it does not estimate the future risk of periodontitis progression. So grade A, grade B, grade C, that tells you how fast the perio is progressing. So that is with grading, not staging. Let's look at this one. This one is C and D. Both of these are to do with grading. Grading does estimate the future risk of perio progression, whether it's going to go slowly, moderately, or progress rapidly. And it's also going to estimate the interaction. So diabetes and tobacco and smoking, there is an interaction, a negative interaction with that. So C and D is the correct answer for this question. Let's look at these questions. You need to pause the video to look at these questions before I tell you the answers. So here the answer is non-surgical periodontal therapy, or NSPT, and this is basically debridement. It also includes education, whether it be oral self-care education, tobacco, or nutritional counseling. They all fall under non-surgical periotherapy. Non-surgical because you're not doing surgery. This is the best type of treatment for someone who has slight bone loss. Regenerative perio surgery, that's for someone who's got really deep pockets, maybe like a 6 millimeter pocket with inflammation and like have furcations. This is when this would be a periodontist would take over and do this surgery. Gingival curettage, this is basically when it's actually a surgical procedure and it uses a curette. And what it does is it removes the soft tissue lining so that all that's left behind is the inside connective tissue gingival, like inside connective gingival tissue lining. So there's studies that show that there's not really any therapeutic advantage to doing a gingival curettage over perio debridement. So this is not an option. Oral prophylaxis, this is basically for someone who is healthy and you just want to, give them a polish and a quick debridement, nothing fancy here. And then periodontal maintenance therapy, well, this would be after treatment. So if we had done a successful non-surgical periodontal therapy, or if we had, debrided them, then what we can do is we can then put them in a maintenance program. So either 6 months, 3 months, given that they're perio, probably every 3 or 4 months. Number 6, which of the following would be the best indicator of treatment success at the re-evaluation appointment 4 to 6 weeks after initial periodontal therapy? The answer is C. So the number 1 indicator that the inflammation has subsided is bleeding. If there's no bleeding, hence no inflammation, that is your best indicator of treatment success. Okay, this is your best indicator. Yes, all the other ones are important, but not as important as no bleeding. relatively free of plaque biofilm. Well, every 12 to 24 hours, you're going to have plaque biofilm. It's just, as long as a person is doing a good job removing the plaque, it shouldn't be an issue. Stable periodontal depths. Probing depths are not that essential. I mean, it is important, but probing depths vary from person to person. There are lots of errors in the initial or follow-up probing that can affect comparisons. And a 4mm, let's say someone has a 4mm pocket, and it's now, so let's say it's a 4mm bleeding pocket is now converted to a non-bleeding site, which indicates absence of inflammation, which is good. But is it an area of concern if you have a 4mm pocket that has no bleeding? No, not really, right? Because a 4mm pocket with no bleeding is not a concern. It's considered healthy. So perio or probing depths really is not as important when you compare it to the other points over here, the other options here. And then calculus. If you see calculus, it might indicate that you need to review oral hygiene, self-care, and perhaps redebride that area, but this is not the best indicator of treatment outcomes. This is. Let's do one more question. I'll let you read it and then you tell me what you think the answer is. So the best answer here is A, because if you see a 2mm, so from a 4 it went to a 6, and so a 6mm probing depth, you should probably see that on the radiograph. You would see a change in the bone density or the morphology or height. And the fact that you don't see a change in the radiograph means that this is an exception. All the others are possible. Let's look at some of them. Poor visibility. So 1.5. This is the universal numbering. In FDI is 2.7. So if you imagine the 2.7 is in the maxillary left side, the second molar, and it's further back, so it does have poor visibility, which could be a reason why you can't see properly, why you have that deep pocket, because you couldn't see properly. Calculus deposits could affect your probing depths. Error in periodontal probing techniques. Some people may not have probed correctly. Increased inflammation of gingival tissues, that's all possible, but what is not possible is the continuing clinical attachment loss. There was a probing depth has increased, but clinical attachment loss of 2mm, for example, is very unlikely in a slowly progressing disease, grade A. Remember, slowly progressing. Continuing clinical attachment loss, not as common. All right, now let's look at this classification, other conditions affecting the periodontium, and there's many different classifications, so let's start looking at them. One of the subclassifications is systemic diseases affecting the periodontium. So if you have any of these diseases, it can really make the gums and the mouth look very different, and that would fall under the other conditions of periodontitis. Any systemic disease, any bodily conditions that's affecting the periodontium, that's affecting the mouth, falls under this one. So people with Down syndrome, for example, they might lose their teeth really quickly at an early age. Falls under systemic disease affecting the periodontium. Mucogingival deformities and conditions. So what does that mean? That basically means that there's something wrong in the gums and alveolar mucosa. So what could be something wrong? What could be a mucogingival deformity? Well, recession. Look at how severe these recessions are. That is considered a mucogingival deformity. Look at the frenum. The frenum is it's pulling on the gum, causing a recession. Again, that's a mucogingival deformity. This is the Cairo classification of recession. So there's recession type 1, recession type 2, recession type 3. And if you're looking at recession type 1, it's only, if you look here, you're only seeing recession on the facial aspect. And it's only like a 3mm cowl. When you look at recession type 2, you're seeing it not only on the facial, but you're also seeing it on the interproximal as well, on the mesos and distal, where the attachment loss could be up to 3mm. Recession type 3, now you're seeing significant recession, and on the facial aspect, it could be up to 6mm, and on the interproximal, it could go up to even 8mm. So we're seeing significant recession here. That's RT3. Another example of a mucogingival deformity is when you have decreased vestibular depth. So this is your vestibule right here, and you can see that there's not much of a depth here, much of an indentation here. That could fall under mucogingival deformity. Another one is when you have a strong frenum. That can cause that is a mucogingival deformity, because it's not normal, right? A deformity. It's not normal to have a strong frenum. If you have an excess gum, so gummy smile, that can fall under mucogingival deformity because it is not normal to have excess gums. And abnormal color, so if someone has this, again, that falls under mucogingival deformity. This one is due to an amalgam tattoo, and they did some endosurgery that caused this type of abnormal color. Another category that falls under the other conditions affecting the periodontium is tooth and prosthesis related predisposing factors. So what are some factors that could happen within the tooth that can increase your chance of getting perio? And what about some things that you put on your mouth, a prosthesis that you put on your mouth that can affect your perio condition? Let's look at some of them. First one, enamel pearl. It's really easy for plaque and calculus to harbor around this area, so that predisposes you. That triggers you're more likely to get periodontal disease or periodontitis when you have a pearl. Enamel pearl. If you have an exposed groove, it's very likely for things to get stuck in there, for bacteria and calculus to harbor there. And so again, that is considered a tooth-related predisposing factor, a factor that can increase your chance of getting periodontitis. This is an example of a prosthesis that you just put on, like ortho, and now you can see the gums are severely inflamed because of ortho. So again, that falls under the other conditions that are affecting the periodontium. And then we have occlusal trauma. If you have occlusal trauma, if you're putting a lot of trauma on the occlusal surfaces of your teeth, that again is another condition that falls under the other conditions of the periodontium. Let's just quickly recap primary occlusal trauma versus secondary occlusal trauma. Primary occlusal trauma is like when you're grinding or clenching in an area of intact bone. See the bone? The bone is intact. That's primary occlusal trauma. Secondary occlusal trauma is when you're clenching and grinding and you're putting a lot of strain on your occlusal surface, but the difference is here you've already had bone loss from before. So from before you had bone loss because of periodontitis, and now you're grinding and clenching again, and you're going to get further bone loss. So this is a worse condition, secondary occlusal trauma. Quite bad, because you can get rapid bone loss because you're getting bone loss not only from perio but also from grinding and clenching. So here's a question for you. Occlusal trauma can result in all of the following except A. You don't really get pockets, so periodontal pockets does not elicit occlusal trauma, but all the rest can definitely happen. Think about it. When you're grinding or clenching, you're going to get attrition. When you're grinding or clenching, your TMJ is going to hurt. When you're grinding or clenching, you can fracture your teeth or restoration. So the least likelihood option is perio pockets. The last category in the classifications is peri-implant diseases and conditions. So we have peri-implant health, peri-implant mucositis, this is like gingivitis, and peri-implantitis, this is like periodontitis. Peri-implant soft and hard tissue deficiencies, what this refers to are reduced dimensions of the alveolar bone or ridge that occur during the healing process after tooth loss. So once you've lost your tooth and now you're having bone, like the bone is just reducing in its dimensions, it's resorbing, and the ridge is resorbing, then that's where that is, because there's no tooth. So healthy peri-implant tissues, when we look around the implant, it looks really healthy, everything is nice and healthy, they fall under healthy peri-implant tissue. When you look at mucositis is when you have no bone loss. So I'll just put this slide here. Peri-implant mucositis, also known as peri-implant gingivitis. This is when you have just gingivitis, just inflammation of the gum only, no bone loss. So the gums are inflamed, they might be bleeding, but the bone level is intact. But peri-implantitis, this is perio. This is periodontitis. This is bone loss. in an implant. So the implant is definitely failing here. And we can see that over, actually this is peri-implant mucositis. So there's gingivitis, there's inflammation around the implant. And peri-implantitis is when you have bone loss around the implant. And that's what we see here. This is the implant and you can see bone loss. This is a sign of a implant failure, the peri-implantitis. This is cement. So residual cement has been left over when they put the crown in, and you can see that they didn't remove it, and that cement is causing the bone loss. Okay, so when we're looking at the periodontium, again, periodontium are the structures that are around the teeth. So the gums, the cementum, the PDL, the bone. So when you're looking at the periodontium, you can have 4 different stages: initial, early, established, or advanced lesions. So let's look at them. When we're looking at an initial lesion, this is what it looks like. You can see this is the tooth, this is the root, this is your gums. You can see bacteria over here, but you can see over here that this bacteria has been, or this plaque that has been there, is only there for 2 to 4 days, and we don't really see any clinical signs. So I don't see any inflammation, any redness. Like if you look here, you can see more redness, but here there's no inflammation, no redness. This is your blood vessel, and yes, there is plaque. So what they're doing in the initial lesion is that they're sending the first white blood cell to come out and eat up the bacteria. And the first white blood cell to come out are your PMNs, or your neutrophils, polymorphonucleosides, or PMNs, or neutrophils. So that's your first cell, the white blood cell that comes out to try to kill the bacteria. So that's in the initial lesion. When you look at the early lesion, which is 7 to 14 days, where plaque has not been removed, so perhaps they're not brushing for 7 to 14 days, perhaps they're not flossing, perhaps they're missing the very back teeth, and those areas have plaque that have been sitting there for 7 to 14 days. When they are growing, when the plaque is growing, now we're going to see redness. Now the tissue is going to get affected. Now you're going to see that BOP. You're going to get bleeding on probing, and that's what we see here. You can see that as you look over here, the junctional epithelium is smooth. Now you can see ridges. This is called epithelial ridges. That happens when you get more bacteria entering into the gum, more plaque, and bacteria entering into the gum, and you can see more cells coming out, more white blood cells coming out to kill the bacteria. When we progress to established lesions, so 2 weeks or more, the bacteria has not been disturbed. Now you're getting much more severe conditions. But again, so far, no bone loss has occurred. It's just the inflammation of the gum. More cells are in play to try to kill the bacteria. And then if that doesn't work, and we have advanced lesion where we're getting bone loss, look at how much more cells have come out in that area to try to eat up the bacteria. We can see the junctional epithelium has migrated down, or apically, so the pockets are deeper now too. So these are the different types of lesions: initial, early, established, and advanced. Okay, let's look at what are the signs of someone who has biofilm-induced or plaque-induced gingivitis. Well, we're going to see a change in color, as we see now, red, right? We're going to see BOP, and to be very precise, if you have 10% or more bleeding, that's when someone has gingivitis. We're going to see some swelling. The gums look a little swollen, and we might even see some exudate, some pus that comes out from the sulcus, because as we know, when you have a diseased mouth, you're going to see pus inside the sulcus. But with periodontitis, we're going to have pockets now. So we're going to have 4 millimeter pocket, 5 millimeter, 6 millimeter, and so on and so forth type of pockets. And we're going to look at these type of pockets. There's suprabony pocket that someone could have, or infrabony pocket that someone could have. On top of the pockets, you might see recession. You'll have cals, you'll have furcations, you'll have tooth mobility. These are all possibilities that could happen, and we're going to look at tooth mobility and furcations in a bit. Let's start with periodontal pocket. So there's 2 types, suprabony and infrabony. So again, this is a perio condition. There's bone loss here. If I were to probe here, I would get a deep pocket because the junctional epithelium has gone down. Suprabony pocket, think of supra, means on top, bone. on top of the bone. So the junctional epithelium, which is the very bottom of the sulcus, is on top, is supra the bone. Okay, this happens when you have horizontal bone loss. So this is horizontal bone loss. When you have horizontal bone loss in that area, if you have a pocket, it's a suprabony pocket where the junctional epithelium is above the alveolar crust. Infra, so again, infra means below. Infrabony pocket is where the junctional epithelium is below, is infra to the alveolar bone crest. And this happens when you have a vertical, as we see here, a vertical bone loss. So vertical bone loss and infrabony pocket go together. So junctional epithelium is infra, is below the alveolar bone. Okay, so what are some more signs of perio? Fremitus. So fremitus is like vibration of the movement of teeth. So when you take your finger and you put it on a gloved finger and you put it on your client's teeth and you get them to tap, if you feel any vibration on their teeth, on their maxillary incisors, for example, that's a sign that something could be going on. So it's the vibration of the teeth. So let's actually look at this section over here, inadequate attached gingiva. So one of the things we do in the perio assessment is we look at the width of attached gingiva. And to do so, what you do is you take your probe and you put it outside the gum and you figure out where your alveolar mucosa is, and you measure from the gingival margin to the very bottom of the attached gingiva, so or to the very beginning of the alveolar mucosa. And let's say you got 5. Then you probe and you get 2. So you go 5 minus the probing depth, 2, and you get 3. So 3 millimeters of attached gingiva. That means there's 3 millimeters of attached, oops, actually this part right here, there's 3 millimeters of attached gingiva left, and that's actually good. When you have I'm just going to draw this actually a little bit better for you so that we can see. When you have some attached gingiva left, when you have more than 1 millimeter of attached gingiva left, I should say, that's actually good. It's adequate. But when you have less than 1 millimeter of attached gingiva, when you have very little or almost none attached gingiva, then that's an area of concern because they're more prone to recession. They're more prone to even losing that teeth, or the tooth in this case. All right, radiographs. So radiographs, as we know, you need to have radiographs when we do perio assessment. We can't do a perio assessment without radiographs. And when you look at radiographs, it's sometimes you can even see where the calculus, if it's a calculus that's been there for a long period of time, you can see where the calculus is. You can even take radiographs after treatment and see if the subgingival calculus that was there initially has been removed. You can also assess for overhangs. When you have bone loss, you might be prescribed vertical bone loss, and vertical bone loss is so that we can see the bone level. Horizontal bite wings I meant vertical bite wings. Horizontal bite wings, they don't show moderate to severe bone loss. They might show the early bone loss, but vertical bite wings will show severe and even moderate bone loss. PANS are not good for a perio, for evaluating periodontal disease. Paralleling is good though. PAs are good because PAs can look at the entire bone. So PAs and vertical bite wings are good. As we know, the distance in health, so if I'm looking at a tooth, for example, and I'm looking at the bone should be 2 millimeters. So this is the bone. The bone should be 2 millimeters from the CEJ. This is your CEJ. This is the alveolar bone crust. It should be 2 millimeters. If you see more than 2 millimeters of bone loss, then we have an issue. Then that's a disease condition. That's periodontitis. Bone loss could be horizontal or it could be vertical. And we saw some pictures of that above. All right, let's look at furcation. So let's look at the different classifications. Class 1. Class 1 furcation is when you take this neighbor's probe. Okay, so a neighbor's probe is what's used for furcation, and you can just go into the furcation entrance. You can feel it, but you can't really go in. The furcation probe is not going inside, but you can feel the furcation. That's class 1. Class 2, the probe or furcation probe or neighbor's probe is able to partially enter. So now you can go inside. So maybe you can go inside halfway. You're not able to come out, but you're able to go inside halfway. That's class 2, and you give it a triangle, an empty triangle. This is class 1. Class 3 is now you can go all the way inside, and the probe passes completely through the furcations. And when that happens, you can give it a class 3 classification, which is a colored triangle. And class 4, what is the main difference? Again, you can go back in all the way, but the main difference between 3 and 4 is that there's recession. The furcation is visible. If the furcation is visible, automatically class 4, and you give them a diamond. So that's how you would chart it in your hard tissue chart. Mobility has 3 classifications. So furcation has 4 classifications. Mobility has 3 classifications. To check for mobility, always use 2 ends of an instrument. Never use your finger to assess for mobility. Always 2 ends of an instrument. And if the teeth can be wiggled, 1 millimeter or less, it's class 1. If it can be moved 2 millimeters, more than 1 millimeter, it is class 2. And if it can be moved a lot more than 1 and also depressed up and down, it can be pushed up and down, it's a class 3. Now, radiographs, we said, are essential for perio assessment and when coming up with the periodontal diagnosis. But we know that radiographs have limitations. And so some limitations over here are listed over here. Sometimes we can get like elongation for shortening. So sometimes we can get errors with radiograph. Facial and lingual, we can't really see. We can see the mesials and distal bone, but we can't see the facial and lingual. Early bone loss is not always shown on the radiograph. Okay, so early bone loss is not shown on the radiograph, but it is shown when you do cal. So if you're calculating cal, that is shown. And then it doesn't show any soft tissue, so you won't know where the gums stand. You won't know the gingiva part is not present on the radiograph. The only thing you see on the radiograph are your bones and your teeth, but you can't see soft tissue like gums. Here's a question. What change in the alveolar bone on a radiograph indicates early loss of bone? Fuzziness. So if you see the alveolar crest looks fuzzy to you and not intact, then it is a sign of early bone loss. And so let me show you a picture of that. Look at this area where the bone is intact and look at this area where it looks fuzzy. This is early bone loss because there's fuzziness in the crest of the bone. So anytime you start to see fuzziness, it means there's early alveolar bone loss. What are risk factors for a periodontal disease? What can you have in your mouth that just makes you more likely to get periodontal disease? Or plaque. Plaque definitely triggers periodontal disease. If you have CAL, clinical attachment loss, that triggers you to get periodontal disease. That increases the chance of periodontal disease getting worse, or periodontitis to get worse. The older you are, the more likely you are to get periodontitis or periodontal disease, even gingivitis. If you smoke, that's going to make your perio condition worse. If you're diabetic and you're not taking care of it, that's going to make your perio condition worse. If you if you are going through puberty, menopause, pregnancy, that's going to make your perio condition worse. Leukemia, malnutrition. So all these are risk factors for getting for increasing the risk for a perio to start or for perio to progress and get worse. So one of the things we do when we see clients is we look at the risk factors, and if we have plaque, we're going to teach them how to remove it. If they have CAL, we're going to teach them how to stabilize it. So we're going to tell them what periodontitis is, and we're going to tell them about the importance of coming regularly for debridement and doing proper oral self-care at home to make the CAL stable. So there are some that are modifiable. Plaque is modifiable because that can be changed, but there are some that's not modifiable. Age is not, right? You can't help, you can't get younger. It's not modifiable. But tobacco is, diabetes, you can control it. So there are some things that are modifiable. There are other things that are non-modifiable. Overhangs can be fixed. Again, that is another risk factor. If you have an overhang, you're more prone to getting periodontal disease. If you have xerostomia, decreased salivary, hypo means less, hyposalivation, decreased salivary flow, that means plaque is going to sit there, it's not going to get washed away. If you're taking a drug, such as a calcium channel blocker, immunosuppressive, or an anti-seizure drug, you're very likely to get drug-influenced gingival enlargement, and that increases your chance to getting periodontal disease. And here are some other risk factors that are being studied. They've been saying that, if you have osteoporosis, which is weak bone, you're more likely to get periodontitis. If you are obese, if you are stressed, there are strong links between obesity and stress now. I've been reading research where it says that obesity and stress can increase the chance of you getting periodontal disease because it impacts your immune system. All of the following are risk factors associated with periodontal disease except one. Which one is the exception? Yeah, it is the frequent fermentable carbohydrates in diet. That is a risk factor for caries, for cavities, but not a risk factor for periodontal disease. All the other ones are risk factors for periodontal disease. So, as I was saying earlier, always figure out when you're talking to your client what the risk factors are and if they can be modified, if they can change them. So determine which ones are modifiable and which ones are not modifiable, and then based on that, you make a client's specific treatment plan. PSR is an important section to know for perio. PSR is when you take the highest code, so use a HU probe, which is the probe with the ball tip at the very tip, and you put the highest code per each sectant. And again, I have a video on this. It's actually on my YouTube channel, and if you go to this one here, let's use periodontal indices, it will talk in detail about how to do a PSR. But just to go back and show you, if you have a PSR like this, for example, and you have lots of 3s, you need to reprobe the entire mouth. If you have a PSR that looks like 2, 1, 2, 2, 1, 3, and you only have 1 3, then you just have to reprobe that sectant. You don't have to reprobe the entire mouth. But if you have a PSR that looks like 4, and let's say 2, 2, 2, 2, 2. So everything else is not bad, but the 4 is really bad. Anytime you get a 4, you got to reprobe the entire mouth. So anytime you have 2 3s or a 4, you got to reprobe the entire mouth. But if you only have 1 3, you just have to reprobe that sectant. Remember, the highest score is recorded for each sectant. So again, there's also some periodontal indices that is shown in that video. This is a great way when you're out in the community, if you're ever working for public health and you want to figure out, how many people in the community has periodontitis. An easy way to do that is by doing periodontal indices, such as the ones shown in this video. This again is the PSR probe, the HU probe. It has that ball tip and it has the colored band. So anytime that colored band is covered, I'm going to show you that. It's a code 3 if it is partially covered, and if it is completely covered where you can't see the black band at all, it becomes a code 4. When you put an asterisk, it means there's a mucogingival defect, and a mucogingival defect could be a furcation, could be mobility, could be recession, that's 3.5 millimeters or greater, and if those things happen, you're going to put an asterisk beside the number.